So I'm just going to present this paper. So prolonged ketamine infusion modulates limbic connectivity and induces sustained remission of treatment-resistant depression. So um, there really is two kind of separate parts to this: the imaging and kind of systems neuroscience part, and the clinical trial part. And so, I just want to make sure you at least get some sense of the results from each. So a little background to start off. So it's a certainly unusual sounding intervention. So it's a 96-hour infusion. And where does that come from? So we know that, the antidepressant effects of ketamine bolus are rapid, sometimes within a few hours, and can last around 7 days. But this prolonged ketamine infusion, there's actually been studies of as anywhere from 4 to 14 days, typically with hospitalized patients. And it has this kind of astounding result that's been reproduced where we see relief from chronic pain. And that's kind of sub-anesthetic dosed ketamine for up to as long as 8 months. And so we wanted to try this similar approach in treatment-resistant depression. And actually we had published feasibility, or the group that I'm working with had published a feasibility study with 10 subjects showing a good sustained response with this 96-hour infusion. And then then there's the neuroscience side, kind of switching back and forth between the neuroscience and the clinical side. So as far as the neuroscience side, I just want to make a point here, which actually goes back to a really nice talk, I guess, a couple weeks ago by Dr. Morris at the Ketamine Journal Club, in which they looked at subgenual anterior cingulate connectivity. And I think the story with the subgenual anterior cingulate is very nice. It's been pretty well mapped out in some respects, showing that, we know that the area in general plays a critical role in response to emotional stimuli and reward. And feedback, I should probably say, and that in depression, subgenual anterior cingulate shows increased response to emotional phases and to positive and negative feedback, as Dr. Morris discussed. And this area has increased metabolic activity in psychiatric illness and increased connectivity with a default mode in depression, and that some some of these abnormalities normalize, not just across different treatment modalities. So it's been shown with SSRIs, TMS, ketamine, that various aspects of this kind of abnormality normalize with treatment. But the point that I want to make here, and this shows a nice result with overactivation in depression from Dr. Morris's talk. I just threw that in because I thought it was very nice. But the point I want to make is that changes in the rest of the limbic system are much less well understood. And a part of that, at least, is because the signal in those areas and subcortical structures, so the hippocampus, the amygdala, medial thalamus, nucleus accumbens, there's challenges with getting good signal to noise ratio in those areas using MRI. And so historically, often they've been ignored or just have had, unreliable results. And however, and I think probably many of you will know this, but the neurotrophic stimulation of the hippocampus produces rapid antidepressant effects. And this has been shown to be clearly, critical for ketamine's necessary and sufficient for ketamine's antidepressant effects. So it's certainly, of importance to look at those areas. And this is just reiterating the network that the hippocampus has excitatory outputs to all of these limbic structures, including the subgenual anterior cingulate. So, so in terms of our study, just to briefly go through our study design, we took treatment-resistant depression patients, and these are pretty severe. They had moderate to severe depression and had failed 4 or more medication trials. So that was our cohort. The intervention was a 96-hour infusion And I'll briefly discuss that, and if people have other questions about it, we can talk about that at the end. But started at a dose, a lower dose, and basically titrated to a target dose of 0.6 milligrams per kilogram per hour as tolerated gradually. And concurrent clonidine and scopolamine, so an alpha-2 agonist and scopolamine, a muscarinic antagonist, were given to reduce dissociative and cognitive side effects of ketamine, which is also an interesting aspect of the intervention that, if people have questions about that, glad to discuss. And so two things here. One is that we took a matched non-depressed imaging control cohort, so matched on demographic factors, and this was for comparison for the imaging data. But important consideration: no placebo group was used in the study, so it's an open label, non-placebo controlled study, and that's certainly important to be aware of. And so this is kind of a schematic of the design. Basically, important take homes here are 2 MRIs beforehand, and then 1 MRI, and then 4, basically 96-hour ketamine infusion, 1 MRI 2 weeks after, and clinical assessment 2, 4, 6, and 8 weeks after. And I'll skip over details about the resting fMRI, but that's the primary data that we looked at for neuroimaging data. I guess it is worth making the point that careful steps were made to use kind of most state-of-the-art tools to improve signal in those subcortical limbic areas. And I'm also going to skip over the demographics, except to say that these are individuals who had failed on average 8 trials and had a MADRS of 29 on average. And so I'm going to get to the clinical trial results. And so this is the baseline. So now you're looking at, on the y-axis is the MADRS score, and then on the x-axis is the different time points. This red bar here indicates when the ketamine infusion took place. And so there was 2 different time points pre-treatment. And then this is what happened day 5, immediately at the end of treatment, and day 6, the day after completion of treatment. We saw a dramatic reduction in MADRS scores for the majority of participants. And then over the next 8 weeks, a relatively, some diminution of that effect, but a relatively sustained response in many individuals. And so just to put that in numerical terms, I guess we can just look at response rate here, and you can see this is kind of lined up with each time point, that MADRS response, 50% decrease in 73% the day after. And just one more time to say, of course, not accounted for placebo effect, but that response sustained all the way up to 8 weeks in over half of the subjects. So that's 11 out of the 21 subjects still showed a sustained, and this is with no further ketamine treatment, basically 2 months later. So, a 96-hour ketamine infusion produces antidepressant effects that in many individuals persist for 8 weeks. So that's the clinical result. And now to switch over to the neuroscience side of things, there's 2 basic hypotheses that I put out, and this goes back to what I discussed in the background. The first, is that connectivity between the subgenual cingulate and default mode network will decrease as patients recover after ketamine. And again, this one is, I would say, more clearly kind of a replication of what's previously been shown. And we used it partly as that, as you can think of it as a positive control. And then the second hypothesis, which was definitely more, I think, novel or unknown to me, was that connectivity within the limbic system, as defined by these areas here, will change with ketamine treatment. And 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 then as a negative control, we also said that FC within the visual system will not change as a result of ketamine treatment from the 2 time points before treatment to the time point after treatment. And so just to look at the results from the neuroimaging side of the study, this table now is showing, I'm going to walk you through this. So what you're seeing is functional connectivity within, so measured within an entire system defined here, so 3 different systems. So one is between the subgenual anterior cingulate and the default mode network. The second is within the entire limbic system, again, hippocampus, amygdala, nucleus accumbens, medial thalamus, and then the negative control here is the visual system. And 3 lines are this tan line is non-depressed matched controls, and then the 2 blue and cyan lines are the 2 pre-treatment time points. These bars show standard deviation. So this is actually a significant difference for the subgenual cingulate to DMN with basically hyperconnectivity in depression, and also hyperconnectivity in the limbic system in depression. And so I'm showing that here with these significance bars. And then what happens with treatment with ketamine, so the post-ketamine time point, we did see normalization of the hyperconnectivity between the subgenual anterior cingulate and the default mode network. And then we also saw normalization of hyperconnectivity within the limbic system similarly. So this same pattern, basically cortically in, what you could call emotion and mood related systems, and subcortically within the other components of the limbic system, that there was hyperconnectivity that then returned to normal levels after treatment. And then in our negative control, you see no change before and after treatment. So just to reiterate those points, treatment-resistant depression patients relative to matched control had increased functional connectivity in the subgenual anterior cingulate to default mode connections and in the limbic system, and that those connections normalized, both of those areas of hyperconnectivity normalized after ketamine. And then the last point that I'll just quickly make, I don't know how I'm doing on time here. Maybe I have another minute or 2, but just one other point I want to make. So we divided things up between responders and non-responders. So if you look at this, so I'm going to look at the 2 hypotheses here. One was the subgenual anterior cingulate to DMN, and panel B is just showing the response for everybody. So, you can look at the right side here. This is just so you can see individual data if you're interested. This was the response from all individuals. But then when we divided it up clinically between those who, based on MADRS, who showed a response and those who did not respond at 2 weeks, there was a significant effect of decreased, so the bigger decrease occurred in responders. So responders showed a significantly bigger decrease in subgenual anterior cingulate to default mode network connectivity. So there does seem to be a clinical response dependent change in connectivity. And then the limbic system here, I'm showing the kind of similar layout of results. You can see that across the group, there was a pretty nice effect where everybody showed decreased limbic connectivity, but here actually there was not a response dependent effect. So no significant difference between clinical responders and clinical non-responders. Everybody across the board showed well, not everybody, but most subjects, irrespective of MADRS change, showed a decrease in limbic connectivity, which was, you could say relatively small magnitude, but pretty consistent across subjects. So in summary, a 96-hour ketamine infusion produces antidepressant effects that last at least 2 months in many of the subjects here. And a question raised by reviewers was, is a 96-hour infusion clinically feasible? And to that I would say one thing that we had thought about with this intervention is that in individuals who are already hospitalized, either medically or psychiatrically, it certainly, that would get over the barriers of coming in for 4 days, although, that certainly would be a challenge for outpatients. And then in terms of conclusions, ketamine normalizes subgenual anterior cingulate DMN default mode network hyperconnectivity in a response-dependent manner. And ketamine normalizes limbic hyperconnectivity, and I should say in depressed individuals, in a treatment-dependent manner, meaning non-response-dependent manner. And then lastly, future directions that I think are worth considering. One is that certainly, this should be replicated in a randomized controlled trial to include a placebo and account for the placebo response. Secondly, that it's important to clarify the parameters and mechanisms of long infusion. And I think it's worth making the point, we're kind of contrasting here a ketamine bolus to a 96-hour infusion. And it may be, and also we can talk about why it might be that the 96-hour infusion has such long effects. I think that's a really interesting topic, and I have some hypotheses, but people can ask about that if they're curious. But it's important to realize that it may be that we don't need to go, it doesn't need to be a 96-hour infusion to achieve that effect. It may be that, I don't know, a day, who knows? So, understanding that parameter space, and then also, I think using animal models to test out some of the ideas about why this produces a longer response would be worthwhile. And then, I think it's important also to say that we don't really have a clear understanding of what are the implications of limbic functional connectivity. And so that still needs to be, what does that actually mean on a neurobiological level? So that needs to be better clarified. And then lastly, one thing I'm interested in is comparison to other rapid neurotrophic antidepressants to determine kind of common neurotrophic effects on brain networks and understand better what that means on a systems neuroscience level to stimulate nerve growth and neurogenesis. And then I'll end by thanking everybody who was a part of the study, in particular Nuri Farber, who really was the leader of the study, and this was quite a few years in the making, and he's had a long career of really interesting research and contributions on ketamine, and lastly thanking Dr. McShane and Dr. Costi for hosting and inviting me to do this. So let's see, how far did I go over?
You did just great. Thank you, Josh. It was like very interesting presentation of a really interesting paper. And we already had some question, and I also had some, but I felt like Dr. Robinson and Dr. Gill had some of the same question I had. And one was like, do you have any thoughts about scopolamine, like maybe have helped with the antidepressant effect, or maybe what about clonidine?
Yeah, it's
comment on that.
It's certainly possible. So, there's been, interesting research, and the hypothesis that clonidine blocks psychotomimetic effects of ketamine without blocking the antidepressant effects was the basis for using that. And I think it's a reasonable question whether scopolamine in particular could have contributed to the clinical response. Just not known at this point.
And so I think you hinted to this before, but would you like to talk a bit more about what are your hypotheses about the prolonged response, like of these prolonged infusion?
Sure, yeah.
Mechanism.
For following up on my hint, yeah. And this, I have to start with the caveat that I'm human neuroimaging guy, and so this I think is outside the realm of my, and clinical psychiatrist. So this is outside the realm of my expertise. But from reading in kind of what I think is fascinating work on the mechanism of ketamine, it seems that for some of the components of the neurotrophic cascade, so BDNF being the most prominent, the ketamine bolus stimulates translation of BDNF RNA that are already extant. Basically, it does not stimulate transcription of new RNA, and so there's at least the hypothesis that this longer ketamine infusion, which kind of exhausts NMDA antagonism, may actually lead to a more sustained transcriptional change in these neurotrophic factors that are accounting for the clinical response. But again, this is speculative at this point, but I think it would be fascinating to test in animal models.
We have some other question. Some of them were like about the screening phase, like were like the patients still allowed to be on antidepressant, and had any of them received ketamine in the past or received DCD?
Yeah, they were allowed to be on antidepressants, and many of them were, and SSRIs and SNRIs, and I don't believe that any had received ketamine ever in the past. And then you asked about ECT, and certainly none of them were undergoing concurrent ECT, and I'm not positive if any of them had previous trials of ECT. I imagine they have, but I'm just not sure.
I have a follow-up question from my end. This time it would be like ketamine, 30 minutes infusion of ketamine has been demonstrated to have an anti-suicidal effect. Do you notice anything similar for your prolonged infusion as well, aside from the clinical improvement?
Yeah, it's an interesting question, and I really didn't look at suicidality data specifically, so I couldn't comment, nor am I sure if the study would be really adequately powered, but well, certainly as well powered to find an antidepressant as it was to find an antidepressant effect. But yeah, I'm just I'm not sure. We didn't look specifically at suicidality.
And then I think more on the neuroscience, I think side of things, one of your last slide was showing the difference in connectivity at baseline between responder and non-responders. It was like a difference in connectivity at baseline between these two groups as well. And when you say responder, was like, we're talking the responders at two weeks time point for the fMRI, or is like at 8 weeks?
Yes.
Or?
Yeah. So no, that's a great catch. So actually what you're pointing out is that I can just go back to the slide maybe to make it easier, is that this chart right here is functional connectivity pre-treatment and post-treatment between the subgenual anterior cingulate and the default mode. And so the left is responders pre and post, and the right is non-responders pre and post. And what I said was that responders showed a larger decrease in connectivity than non-responders. But you're actually right that the correct, I think better way of interpreting this is that the pre-treatment hyperconnectivity, that those who responded had pre-treatment hyperconnectivity, and it's not so clear that those who did not respond had pre-treatment hyperconnectivity at all. So so at the post-treatment time point really there was not a big difference between responders and non-responders. So that, that opens an interesting question about, whether pre-treatment hyperconnectivity could predict response.